For today, our very first speaker today is Dr. Stephen Wang. So Stephen is going to tell us a little bit about the MAP Center and all this wonderful stuff and research that we do here at St. Mike's. Stephen.
Thank you, George. So thanks for the chance to say a word about MAP. But first of all, I just want to just salute everyone who's been involved in this project for the incredible work that you've done. And I think it just illustrates the real importance of collaboration between research organizations and community-based organizations, and how we can have a greater impact by working together. I just want to call out to James, Gautam, Parvin, George, Ayan, and Evie for all of the work that you've done. And I know this has been a really a labor of love. So just a few words about MAP. The MAP Center for Urban Health Solutions is a research center based at Unity Health Toronto, and one that focuses on the conviction that we need to do work, research and implementation work, to ensure that everyone can thrive in our cities, and that that no one is forgotten. So really, health equity is the focus of our work. And we also recognize that while health care is important, that the roots of health equity really lie in the structures that we create, the political and social and economic structures, and that we need to do applied research that really has an impact on those structures and those social determinants such as housing that really are so critical. So I'm just also really privileged to lead a group of researchers who focus specifically on homelessness and housing as a determinant of health, and how, first of all, we can improve the health of people experiencing homelessness, but even more importantly, how we can end homelessness itself and ensure that people can thrive and become part of communities that are healthy and welcoming. So thanks very much for the chance to just say these few words, and welcome to everyone.
Thank you, Stephen. So I'd like to now move over. Hold on, I gotta change spotlights. Sorry, I've got so many jobs that I'm doing at the same time. There we go. So I'd like to introduce Gautam. Gautam, I'm going to probably get your last name wrong, but I'm going to try it anyways. Makirji, I hope I have said it right, from Housing Links and Mainstay. So Gautam, tell us a little bit about what's going on there.
Okay, I'll be quick. Thanks very much, George, and thank you, Dr. Wang. And if you heard what Dr. Wang said about MAP's mandate, you'll know why we're so excited to work with MAP and why it's such a good pair. At HouseLink and Mainstay, we're a supportive housing provider, and you can see on the slide here, we're a large supportive housing provider, big portfolio, lots of tenants. We also provide some services to people who are not our tenants, so some other community services. But we're very interested, and the role that we play is how we can be the housing provider, one of the housing providers, but we're the largest one here for people who have experienced homelessness. So we're really interested in the research, in particular around what kind of housing interventions work for people who've experienced homelessness, and then what do we do once people are living with us to provide the best quality of life and wellness and recovery for the populations that we serve. You can see on the slide here, our organization is new. We're the product of the marriage of HouseLink Community Homes and Mainstay Housing just over a year ago in 2021. And the merger is sort of a long process for us that we're still working our way through. We're looking forward in the months to come to bringing our staff together into one group. They're still in two groups from HouseLink and Mainstay. And the work you're hearing about today is the research is on work that was being done on the former Mainstay side the organization. The merger occurred because we wanted to have a greater impact on supportive housing and homelessness in the city of Toronto. The two predecessor organizations were both really good, very strong organizations. We were really one of the sort of key things that both organizations were cognizant that we needed to succeed in order to advance our missions, is we needed to get into development of new housing. And so the merger happened. One of the big reasons was so that we create a larger organization with more capacity to develop new housing. And I think the research that's being done, how that informs our development objectives is something that's really critical to us. We got some really good news this week. A piece of land site that the organization bought recently has been recommended for funding under the Open Door program. So we're starting to see the fruits of our amalgamation, and we hope that there's more successes to come in terms of growing the amount of supportive housing that's sorely needed. Finally, just to wrap up, I really wanted to also thank Dr. Wong, Dr. Lachaux, and the whole MAP research team. It's such a privilege and honor and a great opportunity for us to work with you. And I wanted to give a big shout out to Parveen, and of course to our whole team at HouseLink and Mainstay who are delivering the services. Parveen has led an application, which you'll hear about today, for renewed funding for the program that was researched here, and we got some really good news about that we'll be carrying on for at least 2 more years, more than 2 more years. The research informed the further development of the program, and a couple of pieces that were really exciting for us in the renewal were some funding for some specialization around addressing pest infestations in the community, as well as supporting people around substance use. So just some specialization in those areas. Finally, you'll hear in the report about a lot of the findings. I just wanted to call out a couple of things that really resonate for me. 3 things. So one's a really particular thing. You'll hear about the group in the study who were part of the Movein. They were people who lived in our dedicated supportive housing. It's a building with a large 145 studio apartments, all for people who've experienced homelessness and living with mental health and addictions issues. So it's a very unique dedicated supportive housing building. Part of the study was on people who lived there and moved on or moved out. One of the things that really resonated with me was about the poverty that our clients are dealing with, and how that even with a rent supplement or some sort of housing allowance support, the poverty really impacts both the choice of housing and quality of housing that people have the option to move to, and then of course impacts their wellness and their access to food and other essentials when they leave. So while they're with us, we can help with a lot of those things, and when they move on, although there's more autonomy and maybe they'd like living in a different setting, but there are these other issues that really require some resolution. You also hear about the impact of COVID, and I think in all of the domains, you had a huge number of people saying that COVID had a very negative impact on them. I think with COVID, as a society in general, we're talking a lot about isolation. And, I would just sort of say to attendees here, there is learning for all of us coming out of the negative experiences of marginalized people from COVID. We really saw both in our communities where we deliver supports, and also for people who've moved on, the difficulty of accessing community-based services and the reduction in home visiting from previously home visiting services was I think something we really need to look at as a community of service providers, and I think really contributed to isolation and other negative outcomes. The other thing we're really interested in talking to MAP about, we sort of always struggle with what is the right metric or measure for the effectiveness of housing and of supportive housing. Is it how long people live with us? Is it how many get connected to primary care, re-entering the labor market, all different kinds of metrics that we're always trying to think about. I think one of them we're starting to think about more is what is the impact we have on people's life expectancy? And you'll see here in the report about mortality, and we certainly saw a tragic increase in morbidity during as a result of the pandemic. And these weren't people who got COVID and died from COVID, but we know it's related to using substances alone. It's related to isolation, increases in depression. So these are, I think, some of the things that you'll hear about from Parveen and from James as we go forward, and wanted to call out some pieces that really resonated with me and some that I think we'd like to turn our attention to as we look at future pieces that we want to research. So thanks again. I hope you all enjoy the session. Thanks for coming. George, thanks for hosting. And I'll sit back and learn like many of the rest of us. So thanks for your great work.
Thanks, Gautam. So I'm just going to your spotlight. And I'm going to introduce our session for today. So we'll be doing the Homes for Good, and Parveen Merchant from House Links and Mainstay will be talking first, and Dr. James Lachaude from MAP Center. So I'm going to introduce Parveen right now. And so Parveen, take it away.
Thank you, George. And thank you all for joining us today and this exciting work that we took on and the learnings that we're going to be sharing with you. So the agenda for today, we're going to be talking about what is Home for Good program, what was the objective, which Gautam already touched. We're going to show the model that what we have used here at HouseLink and Mainstay. Dr. James is going to talk about the research and the evaluation piece, the work that was done, what were the results, what came out of it, the recommendations or the key takeaway from the study. And finally, I'll come back in again to talk about what was the recommendations, what changes or what pivoting we had done from the recommendations, and what we look to do moving forward as well. George, I'll ask you to move the screen, please. Perfect, thank you. So this one here talks about chronically homeless people. As we all know, they bring extraordinary complexities. So here this slide talks about the extraordinary complexities that we have been seeing when we house this population. They all come with physical health issues, mental health, alcohol, drug use, discrimination, food insecurity. The interplay of these complex challenges and the experiences that these people bring, or the discrimination that they have faced, and they have internalized the stigma around this, affects everything that follows with them, or their ability to be successful in the housing. So the program, that the support that we need to bring should have all of the capacities to address these complexities and to work around all of these challenges that would become, to build their confidence within themselves and the society, which is really hard to do, but that's what we have been doing all along. So I'll get into what it would be in the next slide around what is that Home for Good program. So Home for Good program, here we provide permanent and affordable housing, which is place-based, that is on-site, the support that we provide. It is a housing first model along with the harm reduction, recovery, rights-based, trauma-informed support that we provide to individuals for the community integration and for the housing stability. The way this program at Home for Good works is when people move in, we provide them with step up, or other way to say it is intensive support, where our supportive housing worker provides some functions of case management as well, but they provide intense support for that they remain housed, because the first 6 months to 12 months is very critical to keep this population housed. There's a lot of challenges and a lot of work needs to be done in those earlier stages. You providing life skills to making sure that they have ID, the financial stuff that they need to keep their house so that the rents are paid on time. So all of those, as well as transitioning from street to a home, and what does it mean to be there and to live independently. So that's the first piece where we provide an intensive support. And then later on, once they're a little bit settled down and require a little bit less, then we connect them to the community partner agencies for other supports. We'll provide moderate support within the building, where they come to the building and provide. That also takes us to the next topic about what is the move in and the move out component, what Gautam was talking, that this program is a little bit different about. That move in is this when we accept the referrals from the city to this program and they come and live in our building. We provide them with high intense support. Once they become stabilized and ready to move on to the next phase of their life, they have their own autonomy to choose whether they want to move out of this building to live into the private market. We support them to find the other housing into the private market. So that is the other move out component or move on component, where we will be supporting in this program individuals to live into private market. And we continue to provide them with the ongoing support. So this program, the Homes for Good, was based on this model of move in and move out. The way it was that once we have individuals moving out, we will create some room and vacancies within our program to take the move in. So the people living on the streets, we'll be able to bring them within our building. So this program started in November 2018. This is especially for single adults who are experiencing homelessness, and its program is being funded by City of Toronto. So when I talked about place-based support, so what is a place-based support? What I'm saying is the supportive housing workers are doing on a day-to-day basis here, that they provide mental health support in their recovery journey, wherever they may be. We worked with them for the physical health care. When they come in, we ensure that all of them have connected to the primary care services, to the doctors. We support them in their advocacy role to communicate with the doctor their issues and the challenges. We create a sense of community so that they feel belonged within the building and outside around where they're located, whatever it may look like. Their goals can be in volunteering, employment, education. We try to merge all of those and cater their goals and work on those pieces. In-house, we do provide community development programs, which were on hold during COVID time, but we play a big role in providing the community development at the building, so that reduces isolation as well as builds the community for them. The other main piece is that the moral is that we want to keep them housed. So as long as we can keep them for as long as they really want to be there, that is our main goal. So we provide all of the other support that would increase their quality of the life and housing retention for years to come, 5-10 years. It's not just for 6 months or a small goal, but we really want those to be our longer term goals. So just to talk more about what the program is, as I mentioned that it started in 2018, but it was late 2018, somewhere around November, we just started. Our first move-in was in 2018, December, that somebody moved into this program. Our program implementation was very high during the first phase in 2019. It fell a little bit down as the COVID started to hit. So in the first phase, we had 20 people move into our building and 4 tenants moved out or to the private market in 2019. 2020, with the start of the COVID, where it hit, it just impacted the service delivery. We paused for a little bit to understand what are the public health measures and to put those in place. But that doesn't mean we stopped working. Our staff were at the site. We did continue what we were doing, and we continued to house individuals. So in 20, we house 12 individuals and 4 individuals more that fund private market units. 2021, we could say that yes, we were now a little bit clear about what it should be, and we pivoted and changed a little bit to our service delivery model. And we continued to house people. At that time, we housed 11 individuals within our building, and we were able to find 3 individuals private market unit. So in total, in these 3 years, the project was funded for 3 years. So in this 3 years, we were able to find 11 private market units. And in total, if I count 2022 move-ins, we had housed 46 individuals within our building. Just to mention here that within the 3 years, at the end of the 3-year mark, we had the Movein model halted as there was not much funds there, and the other challenges which Dr. James is going to be speaking about. Also, I would like to say that from the recommendations and what the report brought this, we made quite a bit changes within our model, as well as what the learnings came out, we were able to submit little bit different kind of a model which got them touched on, which I will be speaking at the end as well. So we were able to submit that application. And yesterday we got the news that our funding has been approved. So I'm pleased to share that we will be funded for the same program for the next 3 years with the recommended changes that we put it in there. So coming to the next point of it is that this is where we provide housing. We all are experts in providing housing and the supports within these parameters. We are really good at the services and the support that we provide. But we always have chances to improve, where there are places where we can change and improve. So that's why we really thought that the research and this evidence-based action that we have taken was there for us to improve. And we really value those pieces because there is somebody else coming from outside, taking a glance at what we have been doing and recommending things that we can improve. And or as a society, we can make a change because we are here all to make the change. So the purpose for this is to address the gaps into the system, not just within us, but also around across the continuum of care for these homeless population. So that brings us to the research and the evidence-based work that Dr. James and his team has done. And we can continue to hear from them what it is all about. So over to you, Dr. James.
Thank you, Movein, and thank you everyone for being here. And as Movein was just saying, I mean, the idea is somehow to bring research to a community-based, project, and to really support them and to say, okay, that is the gap, and to what extent, you can take some action to improve those. The first thing I want to mention is like a partnership agreement between MAP, Center for Urban Health Solution, and HLMS. But I have to mention that all the research team members for that evaluation are working for St. Michael Hospital. And they're really acting like completely like independent from Mainstay or for HLMS. It's really like everything come from St. Michael Hospital. And to make the evaluation, we get the funding, from CIHR, the Canadian Institute for Health Research. We get it, all aspects of that evaluation. And also I want to mention that that study was like approved by the St. Michael, Research Ethic Board, to say, okay, that is what we're going to have to do, and that is all the ethic principle we have to observe. And the last thing I want to mention before really going to the evaluation is just that all the participants, all the person, we talked during the evaluation, all of them consented, formally by writing to participate. And all the data and information, was anonymized, to protect, participant, confidentiality. Please, can you move to the next slide? Oh. Okay. Well, the first thing, talking about the evaluation, at the beginning, it was like a little bit before COVID-19. And we didn't expect, COVID-19. So the evaluation, when the team was thinking about it, it was like making like a two-phase evaluation where we're gonna have to make, the first data collection and to compute, some indicator to really understand how the project is working. And then, one year after, to make, another data collection and to have, the data, and somehow we combine both the data we collect, both, the administrative data with mainstay. And we're also, making some kind of comparison, with other similar programs. And then the COVID-19, just start, when we're making, that process. So we have to make, some adjustment. Because with the COVID-19, everything changed. The way we're doing things, the way the program, even though the program, have some kind of design, a lot of things, happen. So we include, the COVID-19, in that evaluation, to understand, okay, to what extent, the COVID-19 impact, the program itself, but also, to impact, the tenant and the housing worker. So before, really go to the evaluation, the first thing for that project is trying to understand to what extent, COVID-19 impact, the design of the project, what changed, what at the beginning, the plan to do, and because of COVID-19, a lot of things stop. And to what extent, what are, those implications for the program. And what we observe, we can see, there are like, two main phases, in the COVID-19 pandemic. The first phase is really, the early phase of the pandemic. And at that period, in March 2020, like almost like other institutions, there are like a time of confusion where, okay, there are that situation, what we can do and how we can do that. And during that period, what happened, most of the activities, stop, to say, okay, how we can adjust that or what we can do. And there was, some kind of in-person activity, like counseling session or some group activity. And everything put on hold and to really revisit them and to say, okay, what they can do and to address that. And also the first phase, there was like a lot of like focus on, okay, how to provide, workers and the tenant, access to PPP, personal protection equipment. And also there was like, a good shift, to food insecurity, to food access, and to find, the way, to really, provide food, to the tenant. That was, the first phase, that what we observed. And then after that period, there was a lot of like adaptation in the program. One of the things, we see is like there was like a shift, to remote service access. And in that case, Home for Good program, distributed, fund and provide, some access to internet and trying to move, some kind of services online or by phone to facilitate the tenant, to stay in contact with the housing worker. And we also, personally, I go, to the building and there was like many renovation and many, the counseling room where they are, making like a little more bigger and also to have, plexiglass, also many adjustment and the staff room to facilitate access. There's still, focus on PPE and food access. And at that period also, the Movein program that was stopped, during the confusion, reopened and to start, receiving people. But the Movein program, was still on hold. And at some point, during the pandemic, it was completely stopped. And one of the things, those adjustments, make, for the program, and I will say, up to the time of the survey, when we go and we make, the survey, the building really avoided, any, COVID-19 outbreak, because, the measure is really, really helpful, to really help, to keep, the COVID out of the building. But in terms of implication, if that affect, the program, but we also found, that has a lot of implication for the tenants and also for the housing workers. The first thing, the way I just showed, we just see the graph. The first thing is just talking about social distancing and stay at home. The very first effect is really create like some social isolation and loneliness for the tenants. And what happened? Most of the tenants are already like living alone individually, and now they cannot go out. They cannot really like go to mix with people, and that create, that really increase automatically, I mean, the situation, I mean, to stay isolated and to be alone. And what we observe, I mean, when that happened, that create, I mean, two issues. And as you can see on the left, that create like a lack access, I mean, to external support, because many of the support, whether we're talking about, I mean, healthcare or some kind of community activity, everything at that period was closed for a time. So it's just like the situation increased. So they have like a huge social isolation. And at the same time, the external support, I mean, all stop. So they cannot access to that. And on the right side, I can see that indeed have like some kind of implication that will increase the symptoms for mental health and alcohol use, I mean, among, I mean, the tenants. So they are alone and they cannot have access. So the situation deteriorated. So that will affect that. And that model, as we can see, what really happened after that, just since they cannot have access to the services and the situation, I mean, really deteriorated, they only have only one support that left. And that only one support is really like the staff, the housing worker. The housing worker, I mean, to support them, the housing worker, I mean, to go to talk with them, I mean, in the middle of the pandemic. And even though they cannot have access, I mean, to still, I mean, trying to make their job. And it was like the only base at that period, I mean, to support, I mean, the situation. And some of time, I mean, they feel, I mean, they wasn't, I mean, fully, I mean, trained for that. I mean, whether, I mean, to deal with mental health, to deal with some situation. And that create a really huge, I mean, burnout, I mean, among, I mean, the staff worker, and also that a lot of staff, I mean, move out, I mean, completely, I mean, left, and other new staff, I mean, come in. So that situation at the end, it's really have a lot of, I mean, COVID have a lot of implication for the tenant. And the housing worker, like they really the base, I mean, to support them. Also, at some point, I mean, have to, I mean, be, I mean, all the burden to really work with them to find a way, I mean, to deal, I mean, with all this situation. And now, just to say, let's talk globally about, I mean, the moving outcome of the program. At the beginning, the program really want to house 60 individuals and the moving part. And what happened up to the time, it was up to 46 people, I mean, was housed in the program. But in those 46 people, what we observed, I mean, there were still 37, they're still housed, but we observe also some kind of other movement. Unfortunately, observe, I mean, 6 people that passed away. There's also one case of eviction, a tenant who have, I mean, some issue and they fill out eviction. There's one tenant, I mean, that move out of the city, and the other case, I mean, the one is someone, unfortunately, I mean, that relapsed, I mean, into homelessness. And that person's not like, I mean, because of eviction, it just like, okay, leave the house and go back, I mean, on street. And for the move on component, what we observe, and as I've been mentioned, we have only 11 individuals that move to private market, I mean, over the time of the project, of the program. And we wanted, I mean, in the evaluation to understand what happened. I mean, why only, I mean, 11 people. And we found to move to private market is like something a little complex. First, there's what we can call, I mean, the structural housing market issue. And one of them is housing price. So to find affordable house at some level of price is something, I mean, really complicated. And after that, there's a lot of other documents, I mean, to provide, whether we're talking about ID, government ID, or talking about guarantor. It's a really, I mean, whole process that really affect, I mean, that component. And also we found, I mean, a lot of discrimination. When I said discrimination, some people even talk about like because, I mean, they know they're on ODSP or OW, that is a reason, I mean, to not have access to house. There are also discrimination, I mean, related to mental health and also racial discrimination. And at some point, I mean, the program stopped because it was really hard to have people to move to private market. And what happened, like an unexpected outcome, is there were, I mean, many people that was on the list. I mean, we did start looking for private market. I mean, that was a private market house, and the people, I mean, stay in some kind of in transition because they were about to move out. They are already, I mean, make all the process, And since the program, has no longer money to complete that, so those people stay in the middle. So it's just like they're in transition, but on the time they don't know exactly what will happen and when they will be able to move out. Now let's talk really about the evaluation. For the evaluation, we use a mixed method design, and we combine at the same time focus group, working with the housing worker. And also after that, also we make a workshop where after all the data were collected, we go to the housing worker, we present the result to have some discussion to understand how to interpret those results and what happened to really make the link between the result and the program. We have also qualitative survey with the moving participant, and also a quantitative survey with the moving participant, and qualitative interviews. So globally for the data collection, as I mentioned, we have one focus group and one workshop with housing worker. For the people and for the participant and the moving component, we 12 tenants participate in both qualitative and quantitative interview. The same tenant in both, just to ask the same question, not only to have like some kind of quantitative indicator, but to really dig in to really understand what happened. We also have 9 qualitative interviews with people from the Movein. And for those left in transition, the people on the list, but they don't know when they will move, we make also 11 qualitative interviews to talk with them, to understand what happened and how they feel what happened. So for the interview were conducted by a peer researcher, a member of research team, including me. All the interview were done remotely, through Zoom. It was COVID-19 period, but to facilitate that, what we do, we set up in the building like a room with a laptop. So the tenant can just go and they have access to internet, and there are someone there to help to troubleshooting thing if anything happened, so to be able to participate. And the time for the tenant participation also was compensated. So just to give you a rapid profile or a rapid idea of the people, of the participants of the study, we can see in terms of age, there are like young people, and also there are older people, from 20 years old to 70 years old. But on average, the group is 47.8 years old. There are like more men, 8 men out of 12 people, and there are 7 white people and 3 mixed people. And as you can see in terms of marital status, they are whether single or divorced or separated. So they are really like individual, living alone. And only 2 of them have kids. In terms of like the profile, we try to build some of the first homelessness episode in the life to understand, what it's like, to come at some point to live that way. And as you can see, most of them actually have at least 2 or 3 homeless episodes. Whether go from shelter to shelter, or shelter to a coach, and to go back to shelter on street. But it was really like a complex situation. Homeless and not homeless are different episodes. And when we look at the lifetime duration homelessness, we can see most of them as at least 5 years to 10 years, but there are many of them also that at least 10 years or more, like experiencing homelessness. And the highest number, was 30 years. So one of them, experienced homelessness for 30 years before moving to the program. And we really asked them in the qualitative interview, to talk a little bit about that experience. And just to say, the first one just say, I was homeless for the last 10 years of my life, and I have had a really tough time as a young man living in the city, securing stable housing, spent a lot of time on the street, a lot of time going to different jobs in around the city, spend a lot of time waiting shelter and stuff like that. The last 10 or 15 years of my life have been basically a roller coaster. I had some addiction issue, and why not maybe some undiagnosed mental health like depression. And after that, we asked them directly, what does that mean now having like a place to stay? What does that mean housing for them beyond the place? What does that mean? And there are many words, that come to really express that, like privacy. I have my own little privacy to do whatever I want to do. Or that housing really help them to affect, the lifestyle. Also, just having housing because of the cold weather, also the reckless lifestyle, just like all that really affect them. Or during the COVID-19, some people was really like, okay, knowing that during COVID, when you hear them say, stay home as much as possible, and I can. I don't have anybody in my place, whereas in the shelter, I was in a room full of 5 women. I'm thankful. And other also explain, even though housing was something really, a good thing, but some level of difficulty, or how they feel when they are moving, at the moment they are moving, the first week, in the house, in the place, how they feel. And some people talk about, the difficulty, they had, like, it definitely was very difficult. At first, I really moved with nothing. I literally had a bed of clothes, and that was it. So even talk about, the fear, the why, the about what they heard about the building or the place. And even though some people still feel like, okay, that was a really good thing. They feel, some level of security because now they have, their own key, and they feel so secure behind, their own locked door. Yeah. And that is, the way, the tenant express about, having now a place to stay. No, I also asked them, okay, now you have a house, you have a place to stay, but what do you think, beyond, all that you're talking, what do you think, that need to be addressed? What need, in terms of housing, you really think about that still need to be addressed? And there are 2 terms that really come out. The first one is really having like a better pest control. And when they move, and if they have something like that, a pest infestation, it would be good. They can receive, a really rapid, answer to really address, that issue. And the other issue, the main risk is about, some security issue. And that is, with other tenant, sometimes coming late at night, they explain, tenant out, drinking alcohol or use, and because of that, they don't really feel secure. Now, beyond housing, being housing, is one thing, but the tenant really face, a lot of other issues. Many, living on street for so many years, like I thought, one of them up to 30 years. We observe, many like health issue and many chronic condition. And as you can see, in the graph and the figure here, at least almost every participant have at least one chronic condition, at least one chronic condition. And most of them have at least 2 chronic condition. And those chronic condition, there are many of them that really like, related, to living condition, whether we're talking about, back problems, chronic headaches, skin problem, dental problem, food problem. Many of them is really related, to the experience, the homelessness experience, but also there are other problems like high blood pressure or hepatitis C and other problems. But we can see some, the homeless experience also really affect their health, and some really, chronic condition is really like the result of having spent, so much time living, on street or in shelter. In terms of mental symptoms, mental health symptoms, we use an indicator that called, the Colorado Symptom Index. That index is a list of questions about, how they feel, and if they feel, some sleep issue, and a lot of to really see, the different symptoms, they have. And based on that, we computed an index. And looking at that, figure on the left side, we can see almost half of that of the participant at least, show some high severity in terms of mental health. And based on that index, when people have, that high severity, it will be good at least, I mean, they have, I mean, like some kind of, I mean, medical diagnosis, I mean, to know, yeah, it's just a screening tool we use, but that means, okay, that is like an indicator that they might require, I mean, additional support. And also we ask them about now, okay, to what extent they really think, I mean, they feel that COVID-19 affect, I mean, the mental health. And as you can see, I mean, on the graph on the right side, almost, I mean, 67%, I mean, clearly say, yeah, COVID-19 really worsened, I mean, or deteriorated, I mean, the mental health condition. And still, I mean, very strongly. And another 25% still say, yeah, chronic, I mean, the COVID-19 have some kind of impact, even though it's moderate. So globally, almost every one of them say, indeed, I mean, the chronic, I mean, the COVID-19 affect, I mean, negatively, I mean, the mental health condition. And we do this exact same thing in terms, I mean, for alcohol and drug use and COVID-19. And as you can see, I mean, on the left side, I mean, most of them, I mean, have like some kind of alcohol or drug issue, even though 5, I mean, like moderate issue, but still 5 of them also have like really severe issue with alcohol. And when we ask them about, okay, to what extent, I mean, COVID-19 influence the alcohol or drug, I mean, use, as you can see, I mean, a lot of them say yes, COVID-19 have, I mean, really like a lot of impact on that, 44%. Another 20% say, yeah, COVID-19 have like somehow, I mean, a low to moderate influence in terms of alcohol and drug use for them. And now we ask question also about, I mean, the income and food insecurity. And as you can see, most of the participants, only one of them are living on CPP pension, but all the other participants are living like on ODSP or OW. The ODSP is the Ontario Disability Support System, and the OW or Ontario Works. So most of them are living, I mean, those two support systems. And on 2020, the amount of ODSP and OW is 14,000 and 8,796 per year for a single person, respectively. And when we just make like a quick look at the poverty line in Ontario, the poverty line is more than $20,000 per year for a single person. That is just to give you, I mean, compared to what we consider like someone living in poverty and what they're receiving, just to have an idea. And that is, I mean, for that reason, I mean, it's not like something that is surprised to understand in terms of access to some basic, I mean, needs. It's really hard for them, and including like food security. And as you can see on the right side, 42% of them are like experiencing like some high level of food insecurity, and 25% at I mean some low level or to moderate, I mean, level for food insecurity. And of course, as the other indicator, I mean, when they were asked about, I mean, to what extent, I mean, COVID-19 affect, I mean, the situation, 40% of okay, COVID-19 affect, I mean, the food insecurity a lot. And also, I mean, another 20% say, yeah, I have some kind of low to moderate level in terms of access to food for them. And still talking about food, when we ask them, I mean, in the qualitative interview, and there are many reasons that come up, I mean, to explain, I mean, food, I mean, access to food. One of the reasons, as we just mentioned, is financial issue. With the minimal money I get from ODSP, you know, I'm good for like basically half of the month. They also use, I mean, a lot of food bank, I mean, to have access. There's one church a couple of blocks away that has on Wednesday, you can go and pick up a bag of bread and milk and stuff like that. So they have been helping me also. And the other issue we found when we were talking about food is also some of food access, or the cow food is really linked with, I mean, some kind of health issue. As we can see here, I have no teeth either. So I'm kind of on a specialized diet. And also, as we mentioned, some people are like high blood pressure and or diabetes. So that require, some, specialized diet, to keep going. And indeed for financial issues, it's really hard for them, to really keep that. And finally, with that group, we talk a little about relationship and social isolation. I know, that graph on the left side may be a little tricky, but just to help you to understand it, it's like, a circular form. The one is like the worst or the most terrible situation. And when we go into up to 7, the 7 is like the best situation. And we ask them, different questions, and just to see some, to what and what are the situation in terms of relationship with family. And as you can see in that figure, you see, most of those situations, most of the question really, go, toward the one. Most of them, explain, that situation, some it's among the worst, or or the most terrible. And those questions, the question we ask them is a question about how they feel about family and about their family in general. How often, they have like contact with the family, how they feel about the way, the family act toward, each other. So as you can see, in that graph, most of them, really go, on that toward one, that mean close, to the worst situation. And also in the qualitative interview, we observe, almost the same thing. There's no family left, really. Just like I'm completely alone. Otherwise, you're laying one in the bed waiting to die. If you don't have a social network, that's pretty much all you do. It's come and go, and until one day you have a stroke and you are dead. And also some explain, how the pandemic affect them. It's tough. To be honest with you, I am depressed, probably more than anything. I'm basically in my cell. Consider the apartment like a cell, 23 hours a day. Sure, there's got to be some sort of effect on me. I used to have a pretty good social network with the other world. So some, they were already living like with like bad relationship, with the family. And the person who still have, some kind of like open socially, the COVID-19 really affect them, really keep them, inside for a really long time with no one to talk, and also that indeed affect the mental health. So I'm gonna to present so quickly, a few reasons about, the people who move on the private market. One of the first things we observe when we talk about the people who move the private market is really try to understand, the journey, to move, for the mainstay building to the private market. And the people mentioned a lot of, difficulties, obstacles, the meet in that process, including like, okay, they need to have, a government ID. They have like, they require them to make deposit, a payment, proof of stable income, credit score, guarantors, and also the face, discrimination. For them, it was like a really hard and long process to really make, that transition. And some of them really explain, it was really hard. Every place, they check by themselves, they cannot get it. At some point, it was like the program worker who have to step and to go to really help them, to get that. A lot of people, just to quote one of them, a lot of people don't want to take somebody on ODSP. They think you got an issue and a problem, they don't trust you. You're going to give them you are not going to give them the money. I was looking for actively out, doing my own search in the private market for housing. It was kind of draining and a little bit, whatever, disappointing, because I have to hostel to get the place, If there was a vacancy, I have to hostel information for them. My application was rejected. I think when they saw how many sources of income I have, because I have multiple sources of income. So that is just to give you, an idea. And the last one even explain, all my application was rejected. It just to explain, I mean, the difficulty, I mean, to move. And at some point, the housing worker from the program have to stand up to go with them. And the program have to serve like the guarantor, I mean, to support, I mean, the deposit. And to say, okay, if anything happen, I mean, we can call, I mean, call the program and we will, I mean, to provide ongoing support during the process. But what we observe, even though the journey was like very hard and drainful for them, but when they move to private market, that is, I mean, some of the word, I mean, they use, I mean, to express, I mean, how they feel about that. And some of them talking about, I mean, feel safe, comfortable, and quiet. Oh my God. Like this is totally different world altogether for me. Like I say, I'm safe, comfortable, it's quiet, it's close to all of amenities, it's everything I could ask. And the change, I mean, since I'm in the move, I'm not stressed out about it anymore. I'm not worried like I'm getting sleep now. I didn't have because I was getting bitten by bed bug that I'm allergic to. Safe and private, when you have a safe or a private thing that help you to focus on other issue. Just like, okay, now I'm like, I can move forward. And we asked all the participants, both the Movein participant and the people in private market about hope and plan for the future. And most of them, I mean, really explaining, I mean, how now they're trying to really focus, I mean, to have some kind of plan and to move forward. I can now focus like normal shit. Now the future is a little bit brighter, like I had a place, but I was just like a small apartment. I want to at least, get back that independence, that, working on my own, working for my own money, basically I work for it. I can spend it or I spend it. And other value, you're such of limited. I want to have a place where I can stay and still, I can stay there till I die. I don't want to keep moving or to move around anymore. That is just to give you an idea of the feel. So now I'm just gonna have to try to resume. I mean, to give you, I mean, the key takeaway that we have from that study and some recommendation we have made, and after that, to understand, I mean, what action, I mean, each LMS have taken. In terms of key takeaway, the first thing we found is just like the tenet. I mean, yes, homelessness, I mean, is like the common experience, but they really have like a very diverse background and experience. They also have, I mean, a very different level of needs, whether we're talking about healthcare services, type of support or community, it's really diverse. And also in terms of expectation, is, I mean, it's really diverse. Even, I mean, the small group of tenants, I mean, we interviewed, it's really like a diverse group. I would think most of them is something very important, but at the housing in itself is still like a complex, I mean, it's very complex process. And for many, I mean, the experts, I mean, moving to housing, I mean, the experts, I mean, fear, anxiety, joy, I mean, they feel blessed, they feel thankful. It's really like from one thing to another, it's really like really different the way they feel, at least at the beginning. But during COVID-19, I mean, a lot of them very happy because, I mean, housing really helped them, I mean, to add, I mean, to public health measure. And also beyond, I mean, like a place to stay, I mean, the physical place, but also the express housing provided, I mean, privacy, better personal hygiene, freedom, I mean, to still feel, I mean, really safe. And so still have like some like issue, whether we're talking about, I mean, pest control and also, I mean, some kind of safety. For them, I mean, it's still like, I mean, in some housing, like an issue and also a risk factor for both mental and physical health. And beyond, I mean, being housed is one thing. But after that, I mean, the tenant, I mean, still face, I mean, many challenges. Whether we're talking about, I mean, the healthcare condition and many chronic diseases, we're talking about alcohol and substance problem, access to healthcare. And when I say access to healthcare and access to specialists is really important because we're talking about, I mean, chronic disease, food insecurity, social isolation. And also what we observe, I mean, in that evaluation, COVID-19 really affect, I mean, many or most of those problems. And also we observe, I mean, in the building, I mean, what we can call some, I mean, premature aging, and also, I mean, some people aging in the building. And as we see, I mean, the range of age is 23 to 74. Some people are really like experiencing, I mean, aging in the building. And also, I mean, some people, I mean, at some young age, I mean, they are experiencing, I mean, many chronic diseases, a health condition that is like really characteristic, I mean, symptoms. So it's really important, I mean, to consider, I mean, that group, I mean, the need, the really specific need and really specific resources, I mean, for that category. And for the people, I mean, in terms of key takeaway for the people that remain in transition, uh, the qualitative interview, I mean, sure, I mean, a lot of them express, I mean, some level of frustration because they say, okay, we are on the list to move to the private market. And now we get stuck. We don't know what to do. We don't know when that will happen. And some experts, I mean, like they felt abandoned in the middle of the process where they were happy that everything will move on for them. And now, I mean, they don't know, they don't talk, I mean, to them, and they don't know, I mean, what will be the next step. And the last takeaway, I mean, for the people in the move on, the people living in private market, the process of moving was like very long, difficult, and sometimes face discrimination. But at the end, I mean, the participants were very happy, I mean, to have, I mean, a more independent life when they move, I mean, to private market. Even though so many of them, I mean, complain, I mean, or report, I mean, some new challenges about, I mean, cost of living, about, I mean, housing rent, I mean, that keep increasing. So, and also, I mean, some kind of support, I mean, they still need, I mean, even though they move to private market. Based on those results, I mean, we made some recommendation to the program, and that first on that phase one is somehow to use a more holistic approach, and that more holistic approach indeed, I mean, have, I mean, that part of housing, and also to consider the non-housing well-being indicator. But talking about housing, having the place is one thing, but it's also important to consider, I mean, some specific needs, like people, I mean, aging in place that require, I mean, some additional support. And also, I mean, having like an open and safe common area to receive friends and family also, that will be, I mean, something that really important. Many, if they are living in bachelor, sometimes it may be hard to bring some people, but having like an open and safe a place, I mean, that can be on control to avoid, I mean, some, I mean, kind of violence, that will be a really good thing to consider. And also to have like a safe, a cleaner, I mean, place, but mainly, I mean, to have like a rapid and better best control protocol. And when that happens, to have like, I mean, some quick time, I mean, that can be addressed, I mean, that issue, that will, I mean, a lot of tenants will be happy for that. In terms of non-housing well-being, there are, I mean, many things, I mean, to consider. One of them is access to healthcare, including to specialists. Yeah, access, I mean, to nurse and family physician is a one good step. But compared, I mean, to the problem, I mean, the people are experiencing, they really need, I mean, access, I mean, to specialists. Also, it's really important, I mean, to promote, I mean, some other well-being indicator, because compare, I mean, to what the people are receiving, I mean, ODSP or OW, they are really living, I mean, below, I mean, the poverty line, and the Ontario poverty line, and they cannot really have access, I mean, to some basic, I mean, basic need, including, I mean, food, access to food. And it will be also important to consider, I mean, some kind of for social isolation to really act that. When in the program to consider some level of like race and cultural diversity, in a way, the different program, I mean, for integration, need to consider, I mean, the profile of the people, to really include, I mean, some kind of like peer program that the people can have, I mean, different, I mean, interests, but that cultural thing, I mean, will facilitate the people to participate in some activity instead of having like one or two global activity where, I mean, everyone have to go if you want. So that is the more, I mean, the recommendation we provide. There are more, I mean, in the report, and you will have access to it. So just to mention, that was like a wonderful team, I mean, from St. Michael and MAP. And just to see, I mean, the name here, George, I mean, the moderator, I mean, was also part of the research, I mean, with us, and the staff and the funders. So thank you, and I will let Pavin to talk a little more now about what the use of the recommendation and the result of that study. Thank you.
Thank you, James. I know it is quite heavy to take, so we'll take a moment and just keep it a little bit lighter. So here we have a picture of the community development programs that we do in the building. We do have this coffee group that was there during COVID time as well. We just did it a little bit innovative style where instead of people gathering, we just kept a table where people can come, take what they want, take a cup of coffee, and they can go. So I'm just gonna show you a small video of how the table looks like. Sorry, it's just technical stuff. Yeah, here we go. So this was just a picture of the coffee table and where the goodies were stored. We did pivot, and as things are opening up, we started the walking club as well. The next one is your pictures of the food program that we have started. This is where we started cooking within housing. So these are the pictures from there where we've started our commercial kitchen program within the building, because we heard from tenant members during the COVID that they are really missing the warm food where they used to get at the drop-in centers or even in the programs of our own community kitchen program. So at the earlier stage, our staff really worked around to find resources within the community and were able to connect with the food bank to bring some hot meals. But the need was so high, and even from the report's recommendation that there was a really need for cultural sensitive food as well, special dietary needs. Quite a bit of individuals within the building are vegetarian. So to cater to all of the needs, we applied for some funding, and we got some money to renovate our commercial kitchen at the site. We are happy to say last December, we started cooking 3 meals a day, and we've been serving at the site. So this is some from food program. This was just to lighten up and bring us to the more heavier piece of the work. To answer some questions within the chat, when people move into our housing, this is permanent affordable housing, so they can leave as long as they want. They are with us for years. Some of them are here for 15 to 20 years. It's their choice, and that's why when we say move on component, it is their choice based. They are there making choices to find units outside as well. We don't dictate. We had a housing locator as well at the time that accompanied the tenants to find units that were suitable to their needs, closer to their pharmacy and the doctors, or closer to the TTC, whatever their choices were. So we had accompanied them from that base. And we did, so the other question is about relationship within the private landlord. Yes, we did have the housing locator that was working actively within the last 3 years to develop relationship with the private market landlord to get those units. But I'm going to be saying here that the funding was only $800. You and I, we all are aware that the prices within the Toronto are so high. The challenges of finding units within that means was quite limited as well. So coming back to the recommendations of what Dr. James presented, those are all interrelated pieces that we are talking here. So they're all connected to each other. So coming from the food program that we were talking about, it is very connected to the healthcare needs. So this year, we worked with UFT medical students. They came out and did some work around food malnutrition and the effects on the health. And the outcome was exactly the same, that how it is affecting their health with advocacy with ODSP stuff, that they are such a load that is not keeping with the inflation rates. How can we support that as a system as well, not just one, because a joint voice is really needed in all of these pieces of work. So that's first piece to it. The other recommendation that came out with that was also about to continue to provide them with a warm meal, because their income doesn't support that. They have been going hungry for at least one meal a day. It's not about skipping 3 meals in a week. It's an everyday situation these individuals are facing. So coming to the healthcare is that the effects of the health is going to be happening. There are very different silent ones that we don't even know. So when Dr. James was showing about the map of the dying, the pie chart, where we are seeing many individuals are passing. So the reasons that what we digged into it, there were only 2 of them that passed away with overdose. The rest of the deaths are unknown. So we need to do a little bit more work around to find out. Because that's, as human too, the dying alone within the units, we need to have that social component. So with Dr. James, we did apply for a lot of different places for the research fund to fund the study. And I'm really happy to share that we got the funding as well. And we will be starting the new work on that basis as well. The other healthcare component pieces are that we're trying to connect our tenants with the nearby community health centers. But we also have tools and resources in place to support the advocacy. The peer workers usually help them for those pieces. But with the COVID came new challenges where they never went in person. So now we are with a new challenge where all the appointments are virtual. We have been giving out laptops online for tenant members to make those virtual appointments. But it is harder at times when the doctor just wants to connect over the phone and not the virtual meeting. So the tenants need those medical terminology at the same time to able to communicate what is happening. And we are seeing those gaps in between, which we really needed to address. So right now we're working with Toronto paramedics community, where we are looking for them to come to the building and set up like a mobile health clinic, so the tenants get those services within the building and the staff can talk about what their concerns are. Whenever we have the consent, we will be part of those conversations. The other piece that we did was a little bit innovative around partnering with ALC. So we have bringing those services within this building where those services will be available to other tenants within the building. Not the total services, but some healthcare of the nursing pieces around some tenants forgetting to take medications. The acting may come and drop it away and we don't even know whether it was taken. So these nurses would help us monitor those or provide medication on timely basis. So we're looking at different innovative models and stuff where we can support our tenants in a holistic manner to provide them those kind of support. Yes, we are doing programming as well, but all things comes with challenges. So those challenges that what I was talking about, the laptops we are giving them, but then we needed Wi-Fi to have those set up. So we were trying to open up Wi-Fi for tenant members to get Wi-Fi within the building so they don't need to worry about paying. As the limited income, they will not be able to support those needs. Again, those wiring costs were really high. We were not able to get that, but we got somewhere a little bit into it where the Wi-Fi was just coming only in the hallways or around the common areas where we set up rooms for them to sit down. So we got a lot of complaints from the other neighbors around other tenants being very loud, watching music or watching a movie in the hallway. And recently we got a complaint from the city as well because of those loud noise. So we have to make amendments to make those changes that and support tenants to look for other means to have Wi-Fi for their own unit. And I'm sure all of these challenges that I'm talking about is nothing new. We all are facing the same pieces as a supportive housing sector. We do have those things. The other pieces that we noted at this time that the tenants for social isolation piece, that we all went back to our units and we found different means of coping, maybe watching TV, just staying within the unit, doing different pieces of work. What we saw within this population, that some people resort to hoarding as a means of comfort. And there was a very high number or increase of pest control issues within the building as well. And we did hear from the study as well that that was the concern that was raised. We did ask for some funding from outside and support, and some was supported from within the organization, and we called it a pest control blitz, where we provided extreme clean services. We removed their baseboard and did the treatment. Whatever was there within the flooring, if they needed to be repaired, all the sides of the unit to be sealed. If there is any holes in the wall that needed to be worked on, if the sockets, electrical sockets were removed and were treated, as well as we provided heat treatment. So this is a long and extensive and expensive process, which required a relocation of the tenants. So we relocated them for at least minimum of 5 days to another place, provided them with the means to stay there as well as money for food. And we've almost completed pest control BIS in not just this building, but other buildings as well. So that's something different piece of work that we did here. Which I think was very different model and the work that we did, which was never undertaken before. And also, once the furniture was thrown away, we provided them with the new furniture. So it was quite expensive. The other things that what we heard from the tenant members is around safety. Yes, this came with people within the unit, and the use of drugs went up. So came with them trespassers within the building. So now we are working closely with the police, but the other measures that we would like to put in place is install mag locks, which are really expensive. So we are looking at funding and means and resources to have mag locks installed within the building, as well as have fob access within the elevator. So that limits people moving around, or even the trespassers going from one floor to the other. So we are also hoping to have some increased funding to increase the security services that we have within the building. So from one guard to have at least 2 guards, and extend the hours as well. For cleanliness, what we heard from the tenant members, we changed a little bit of our cleaning program and services as well. We do have caretaker in the building, and we have been adhering to all the public health measures at that time. And as till today, we have still continuing to provide twice a day cleaning to all high touch areas, disinfecting them. So all the cleaning materials that we use are approved and sanctioned by Health Canada. So what we did is we increased the number of staff coming to the building so we can provide all of these services as well as cleaning. Over the weekend, we didn't have that before, but now we've added on the weekend cleaning company to come clean up the garbage chutes as well as the common area. As usual, we had the regular process in place for like spring cleaning, where we wax and polish our floors. We provide window cleaning of the exteriors of the windows. So we did all of those pieces of work, but added a little bit more extra to what we were doing from before. So from 1 caretaker to two caretakers for this building. We want to increase tenants' rights on their own responsibilities and their own rights to the housing and human right aspect. We do have partnership with CERA, that is Center of Equality, Rights and Accommodation. They've already completed the educational training for our staff to provide them with tools and resources. We have now started, as things are opening up, for in-person session with them for our tenant members. We have set up our common room with a large TV for our virtual meetings as well. And I think we are doing that so our tenants can view this one as well at this time. But some of the tenants are being accompanied at the same time, as today is the day for the voting, and we want them to speak and advocate for their own rights. I think I covered all of these because this is quite lengthy. And if I miss any pieces, let me know. If you want to hear on any of those topics, I can talk about it. I think I missed about the aging in place, the conversation that we have, that Our tenants here are also, we have a couple of them that are aged 70 plus. So one of them have dementia, and we have been able to keep him housed here. It requires a lot of work to keep that going, because he forgets whether he ate lunch or dinner or breakfast. So staff are doing quite a bit or extensive work to ensure that he had his food. They have organized his unit in a way that the lunch is stored here. Once it's done, before they leave for home, the dinner is there. Over the weekend, they make sure that the food is in the fridge, on the table, and different places. And then making sure that he doesn't go far away from the building, so that way, because he doesn't know where he lives anymore then. So how can he come back? These are all the challenges that we all face in the sector, that there is not much room in the higher supportive housing places. So we are advocating to find them housing elsewhere. We are advocating for these individuals who are aging in place to get peer support as well as personal support within the unit. And to be saying that the challenge that we have is because our staff are called housing worker or supportive housing worker. And when we are advocating or recommending these services, we are never being taken the same way as when a case management would do a referral services. So these are the challenges that we face within the sector as well, that when the referral comes from us asking to get a personal support worker, even if it comes from the hospital, that's fine, they would get it. But we just being the housing provider and being a housing worker, these are our challenges that we encounter. So we are trying our best to provide support in all the areas. So the recommendations from there, that what we are doing here is trying to bring a holistic approach here. And we are including in our new proposal, we asked for a harm reduction worker at the site, because you heard very extensively from James that the services were absent during the COVID time within the building. There were not many services that came. And we saw the need of those clean equipments, cleaner tools, a place to dispose of stuff. So we have installed in each floor shop containers, but there is need for more of these. So we are trying to make our team more equipped with specialized services around harm reduction. Personal support worker. We're going to have a food access worker that's going to also cater to the needs and the nutrition, not just food being there, but catering to the specialized needs. Also the cultural piece there that we want to make sure that has been taken into consideration. The pest control as well, and the hoarding. So if that worker also would be there, part of our team. The other one that we are looking at in their own goals. So we are trying to include an employment worker to come at the site as well. I have not been able to monitor the chat, but after this, I will be able to answer some of those. This symbol is around the aging in place work that our organization has taken into place. We are doing quite a bit of work there as well. So anyone interested can please join us as well. Here, these are the stories of our tenant members. I would rather play and hear from their words so you know what they are saying.
I'm at 550 Kingston Road at the Home for Good program. I'm happy to be here, and this is about it. This is my place, and I like it.
So this gentleman has lost his housing from TCH. That's what he said, that he just did a small mistake and he lost the unit, and he really wanted to be housed. And this program and this housing has really helped him, and he's happy that he's no longer homeless. The gentleman on the side here is, his name is Edward. He is a senior man as well, and he is talking about how this helped him come out of the shelter, because he really wanted to be very independent. And during the COVID time, it really helped him, because we had set up a vaccine site at the clinic, at the building as well, the mobile clinic. So our tenants were able to get those and didn't have to go out, which was really a hassle at times. Because they did express that even going for grocery was creating an anxiety. So we were delivering them groceries to their unit, which they really liked it. Some of the tenants who didn't have phone were given a phone so they can continue to have relations or contact the relations that they had outside, as well as with the staff within the building. And here he talks about that the staff have always been supportive, and he is worried that he may lose his home, but he wants to make sure that he keeps it as well. You want to go on the next one for me? Just some of the quotations of the tenant members.
I'm
The
at
next one.
550 Kings.
Yeah, this one. I would like to say that our tenants are so sensitive about all of us. So the first one that the tenant is saying, I hope you guys like this working year, and because there has been a moment where there was fast turnover. So it's quite touching that they really care about us, and they are also seeing that it's quite a bit of intense work that is happening at the building. And they acknowledge and they appreciate that as well. And some of the comments are like, hot food program is the best, they are liking it. That Mainstay and HouseLink has able to help them overcome challenges. Some saying they like their neighborhood and they feel connected to the community. And last but not the least, as I mentioned, that myself and Dr. James are happy to connect with the community members to continue the advocacy that we are really here to do what this report has highlighted about. So feel free to connect. On the next slide is our name, and you want to put up that so that people who want to leave can have our email address, or maybe in the chat box we can put it out there. So feel free to connect, and we can further discuss how to deal with those issues and challenges jointly.
Sure, I'm going to ask Ayan. Ayan, that's great thing to do. If she can copy and paste James and Parvin's contact information and post it in the chat box, that'd be great. We do have some messages that I'm going to ask, and I know, Parvin, you kind of touched them before, because Sarah's question about what's a time frame. So I'm thinking, can we explain a little bit more about what's the time frame for the move-in? How long do the people stay in the move-in stage at Main Street?
So as I mentioned, that this is a permanent affordable housing, they can stay as long as they want. But if your question is about the move out component, so it depends on each individual when they are ready. When they are ready to live out without those site-based or place-based support, when they feel that they are ready, then it's the time for them to move on.
Okay.
And all of their goals have been achieved, if they have met all their needs, and when they feel that they are ready and independent. And sometimes some people may really feel they are ready, but then there are some pieces of goals that are not achieved, and the staff will work with them to explain those pieces as well.
Okay, because Stephen also had that message about the private sector and the move on piece and developing those relationships. So can you talk a little bit more about what you've done to build those relationships with the landlords?
So the housing locator that we had was working very closely with the private landlord to provide education. That's the important piece, because there's a lot of stigma around in the community around our population. So to explain those and the support, and then the support that is going to come from us. The concerns that they usually have around the payments, that the payment may come from us as an organization, that just helped build those relationships. Some were open for it, not everybody was open. So it's a very small group of the private landlords that are willing to work with us. And there are many other challenges that come along with those landlords as well, that they will expect quite a bit of us paying their bills rather than just a relationship.
Okay, and so Edward has a question about when they move into the building, do you ask, or do the workers ask where the person wants to go back to school, not to work, get more education? How does that work? How does that intake work?
So when I talked about the Placebased, so before that starts the intake, we have a very extensive intake process, and we've added a further step to it called AIM. to assess where they are at, even before the client or the tenant moves into the housing. And the housing worker is part of those assessment way before they move in. So we know what the needs are. And then we go slow to it, first to make sure that they have everything around the community integration. And then we explore with them what their goals are, where they want to go. It has never been dictated by us, but we always take the lead from where they are at, where they want to go. Some may have the goals as education. Most of them, what we have heard in our experiences, most of them wants to volunteer. And would like to be paid for their volunteer, to be very open. They don't want to work full-time, but would like some kind of volunteer opportunity.
Okay, thank you. And I know Edward has some more specific questions. One of the ones is, what building are we talking about? So can we be a little specific with what the building address is?
So the tenant didn't mention that. He said 550 Kingston.
Right. Okay, so it's 550.
I'm just being mindful that we don't want to stigmatize our population in any way.
Right.
Yeah.
Right. So, and if you are living in another building, I would reach out to the management and tell them about this program that we just did. And we'll be sending you out and emailing you the links, and let them listen to the links, and hopefully they can incorporate any of these recommendations that Arvin and James have suggested. And she's asking, how many people are there? At 100, we have 24.
Total tenants within the building?
Yeah.
140 units we have within the building.
Okay, so 140. And James or Parvin, I remember in one of the graphs we showed single, and then there was 2 that had children. I just want to confirm that the children are not living in the building, correct? These are children that they go and visit, because I remember having a conversation with them saying it was very difficult to have the children come into the building because of what's going on in the building.
So as we talked about all of the aspects of these population that lives within the building, so we did mention very clearly that this housing is for single adults. It's not there yet to have kids living, but most of the single adults that come there don't have access to the or come with the kids. If they do, then we try to find them a location that is accessible, as well as having a bigger, larger unit in more sense, rather than a small bachelor unit.
Okay, so I'm going to put you both on the spot, because now we have all the funders, we have everybody here. So James and Parvin, the 21 individuals in transition status, what are your recommendations for these funders and the government people or anyone listening? What would be your recommendation to actually get them to move on?
I think James brought a very good point there, that these tenants are asking that are there in transition, what would happen to me? There is the thing that is still there, and tenants are still calling me till today. Would I have the opportunity to move on? And I do agree, without even looking for funding, and I know Gautam and I will have to figure out our pieces where it's going to be, but it is very challenging to find a unit within $800, and that's the bigger struggle. The other thing that what came out and what we've heard often is the tenants are worried, is this going to be continued? What if it stops after 2 years? What if it stops after 3 years? What would happen if the landlord increases my rent tomorrow? Would it come out of my allowance, which is already a small pocket of the number or the money that they have? How will they be able to take it? So the tenants that we moved them out, we said we're going to take those costs. So all of the expenses about the rental increase is taken by us and not by the funder in this capacity at this time. So it would be helpful to have the base amount to be increased, so that way we can find them a decent house or a place where they really want to be. The other component I would mention here is around premature aging, which Dr. James did touch upon. So we want these tenants that are aging, or prematurely aging. So when they find a private market unit, it is accessible, not a place that they just accept because they want to go with have a lot of stairs or not being compatible to the needs in the units inside. And that's the other fear that they have, that who's going to pay for those unit modification or those kind of pieces when it arises.
James?
Yeah, thank you. Yeah, I mean that is a good point. And as I explained, I mean there's like it's really a complex situation. And even when we talk, with the people, that move to the private market, and just to say, the difficulty to move, to the private market. But at the same time, after the move, many of them, express, how they feel, and a lot of them feel happy and about that, even though they have, many other concerns. Globally, it's really important, to still, consider such a program. But I think such a program will need, not only, thinking about like having, the funding and to move them, but also, to see, the private market, the structure of the private market, what kind of support, we can really provide them in the process, in the search and to move, and also, some kind of ongoing support. And those 21 individual, that is actually in the situation. And since they are already like on some kind of wait list, I don't know exactly, but they need to have some kind of talk, because at some point, they are just like in waiting. They don't know what will happen. And as we just mentioned, Pavel, they're still going, they're still calling, because probably some of them doesn't even know, they no longer have funding for that. So to find, a way, to find like some kind of mid solution, to come and okay, that is the situation, whether they can have, some kind of improvement, in the apartment, or moving, to other, mainstay building. Yeah, because those people, they are already on the wait list, they are already like in the process. Some of them already started, looking for apartment, almost really happy to say, okay, that is, I'm moving. And I think, somehow, I know, that will require, a lot of resources, a lot of focus. But since they're already in the process and they already know that process, they will keep calling, and that frustration, will keep, going up, because just like for them, they will feel abandoned, as some of them express, just like abandoned. They are calling, but nothing happened. Some that talk between, Home for Good, and them, directly, whether, okay, what happened and what other solution we can find. I think they need to have a focus, on those 21 individual, and then to really rethink, that program, the move on part. Yeah, in that case, you will need, additional resources, and you will need to probably go to fight with some funders to see, okay, that is, what is the reality, how we can do that. And that will be like a lot of advocacy. I know that will be very hard, but at least some focus on those 21 individual, we might need, to focus on them a little bit.
Right.
But I should add it before that some of them were transferred within mainstay building. So they who really wanted to move out really expressed those interests. We moved them to other buildings. Some of them are still unsure because if they want to go to the other, because they have developed a community. So some of them want to be on the list but hasn't moved yet. And some of them are searching into the private market only because they don't want to go within mainstay. But they haven't found anything that they really like at this time. But we are already working with them.
Right. And Gotham, you posted something in the chat, so I'm going to put you on the spot if that's okay. I was going to ask, hold on, I'm trying to spotlight you, but I can't. So I'm going to ask you, based on what you just typed, I'm going to propose something. Have we looked? I think we've got two partnerships here. We've got St. Mike's and we've got Housing Link and Mainstay. I'm wondering if there's like a third partner we might need, maybe a co-op or something where that transition part, working as a partner with us, could then help us move and alleviate some of these landlord issues. What's your thoughts?
Oh, am I unmuted here?
Yeah,
No.
you are. We can hear you.
Yeah, I think it's part of the solution, and you know, you can see increasingly sort of participation from Toronto Community Housing as well around helping to address homelessness. I think the difficulty is that you know, on point 4 that I made is, you know, there is a question of, you know, what is this? How does the system work? What is supportive housing? You know, we know that different landlords or different housing providers have difficulties with different kinds of issues that some of our clients face. So, you know, I think a co-op or affordable housing provider is part of the solution around the affordability issues and the initial affordability issues, the annual increases to rent challenges and so on. So it helps with points 1, 2, and 3, but I don't want to understate the importance of access to services and the need for the housing provider to sort of have a mandate around support or housing retention for the populations that we're serving.
Thank you for that. And so I don't see any other questions right now in our chat or anything. And we are running on time, guys. You guys are just super people. So I'm going to add 2 of you to the spotlight, and I'm going to move along. So Parvin, I'll also mention, how do you get in touch with them? So anyone that has access to these slides will have their email addresses. We put it into the chat for you also. So please feel free to, even after today's sessions, you want some questions answered, or you have any questions, or you want copies of some of the slides, please feel free to reach out to Parvin and to Dr. James O'Shode. They'll be more than happy to help you. We'd like to thank you for being here today, but the most important thing is remember to make your voices heard. Today is voting day, so everybody get out and vote today. Make your voices heard. Based on what you've heard today from this session, please make a change for what can happen. So I would like to thank everybody. We've done a great job. Any other questions, please feel free to, like I said, reach out to Parvin, to James, to myself, and to Aon, who's here. Aon, have I missed anything before we go? So I'm going to say thank you.
No, no, I think we're good. Thank you, everyone.
Perfect. Thank you, everybody. So have a great night and take care. And thank you for the presenters for being here. Great job, everybody.